Hello, I'm Professor Jim Hoover, and in this video we will discuss electronic healthcare record systems. Do we call them EHRs, EMRs, or HISs? Is this a matter of you say tomato, I say tomato, or is it something more? Let's take a look. So many highly experienced healthcare professionals use these terms EHR, EMR, and HIS somewhat interchangeably, and I do disagree. I think we should follow the Office of the National Coordinator's recommendations and use EMR, electronic medical records, when we're talking just about the patient's record itself. And we will use the term EHR, electronic healthcare record system, when we're talking about more than just the patient medical records, demographics, labs, financials, and so forth. It's much bigger. And lastly, the term HIS, Health Information System. To me, this can mean any system inside of a healthcare organization. It could indeed be the EHR. It could be a master patient index, an MPI. It could be a practice management system, labs, patient portals, or any other healthcare software. So HIS is a much bigger umbrella term. Electronic healthcare record systems have steadily grown in functionality since their initial conception in 1964 by Larry Reed. But it's interesting to look at the naming conventions back then, which somewhat drive the confusion today, because the naming mimicked the functionality of the paper charts themselves. EMR, electronic medical records. Sometimes they called them computerized records. We also called them computerized patient records, CPRs. Now that's pretty confusing. Electronic charts, I've heard that many times. But really all these terms represent the computerization of medical records, which actually happened fairly early on in the commercialization of computers. In fact, there's really two major adopters. In the 1960s, Mayo adopted an early registration system and what they were calling a uniformed medical record. And some believe that the early adoption of computerized technology was one of those advances that helped really build the reputation that it enjoys today. Mayo was far ahead of its time in computerizing medical records. The United States government has contributed a lot to the science and functionality of EHRs. They developed a system in-house on MUMPS called VISTA, Veterans Health Information System and Technology Architecture. VISTA is still considered one of the fastest performing and most comprehensive EHRs available. A lot of research and development has gone into that, and the industry has often copied some of VISTA's functionality. The Regenstrief Institute should also be discussed here because they're credited with implementing the first modern EHR system architecture, and that was back in 1972, contemporaneous with Mayo and the Veterans Administration. And like many early day computer programs, the data structures were hard-coded into the program and the data was not stored in a database, but it was an early example of the functionality that EHRs have today. The Institute of Medicine, IOM, a division of the National Academy of Sciences, Engineering, and Medicine, is credited with describing the current state of modern EHRs back in 1991, computer-based patient record, a CPR. But they updated it in 2003 to call it electronic health records, the name we use now. And they picked health because it means a state of well-being. The early EHRs started with just clinical data, but this allowed the provider to do computerized order entry, CPOE, so that the computer now contained the notes on the patient care and it was directly stored in the EHR. And it had the effect of standardizing or improving the standardization of clinical notes and readability. Shortly after the EHRs were created, computers were well known for processing numbers, of course, and so financial functions were added to the EHRs for billing and accounting purposes. And then later, physicians started to realize that EHRs were good for the long-term care of the patient, and we started having the concept of longitudinal records stored in the EHR, all the information about a patient over their lifetime. In the early days of EHRs, many common components were standalone, separate software applications. Registration and patient demographics examples, as is finance and billing. At times, clinical, registration, and finance were all completely separate applications. But over time, these satellite systems have been incorporated inside the core of modern EHRs. It's not always best practice, but it's a common practice. There are many providers today, however, that still use special purpose registration systems because they do tend to be better, best of breed, in a smaller application that's purposeful built for a single function versus a more general purpose, much larger monolithic system. That's a philosophical discussion, but it's a valid one worth considering. Now EHR systems are really big and really expensive. More and more features have been added, making them more complex, more costly to maintain, more costly to implement, and takes much longer time to do, and full of risk. But these common components, like scheduling, patient portals, communication systems, document support, and others, were really external products at some point in time. Even reporting systems. Some EHRs have more functionality than others, but there are always third-party tools that can bolt on or work outside of the EHR to give better functionality or additional functionality. And these external functions are sometimes referred to as downstream or upstream. I like to think of downstream as something that relies on the processing of upstream systems. And these ancillary systems, where they exist, are an important part of patient care experience. This is where we get into the best of breed philosophy versus a monolithic system, and it is something worth considering when you're looking at EHRs and special purpose solutions. For example, a downstream search tool or a downstream lab module or cardio module would rely on information inside the EHR proper, inside the MPI, inside the clinical data to do its function, and then would send information back to the EHR. How these external systems talk to the EHR is a subject for interoperability, but we'll get there. Thanks for watching the video. You can reach me on my Charter Oak email. You can reach me at my artofpatientmatching@gmail.com, and LinkedIn works for everybody. So connect with me, like the video, subscribe to the channel, and thanks for watching.